ಶ್ರೀಮಠದ ಗುರು ಪರಂಪರೆಗೆ ನಮಿಸುತ್ತಾ ತಮ್ಮೆಲ್ಲರಿಗೂ ಆತ್ಮೀಯ ಸ್ವಾಗತ. Well, without wasting the time, I would like to begin the panel discussion on OSA, obstructive sleep apnea. It is definitely a challenging medical problem due to its prevalence, its impact on the quality of life, performance either in the school or in the profession, the risk of accidents, the comorbidities associated with OSAs, and the mortality associated with this. So keeping this in mind, we as clinicians, we do face so many patients do come to us. They might not come to you with the typical symptoms. Maybe they come to you with daytime sleepiness, or they come to you with extreme fatigueness, because we have had so many times they just come tumba sustu. Maybe you just go on investigating hormonal, you get a thyroid level done, you get you look whether the patient has diabetes, cardiac investigations you do, but nothing would have come positive. So then maybe you need to have that in mind. See, there's nothing, unless you know about it, unless you think about it, then you cannot put it in the differential diagnosis. So especially our country, many times I you know what, I myself, maybe I would not have asked them about their sleep hygiene. Well, it's so very important that you talk to the patients about their sleep hygiene, you talk to the, and more important is you talk to their partners about the sleep hygiene, what happens. So today I welcome the panelists, Dr. Banu Prakash, the chief cardiologist and is the director of super specialty hospital, Dr. Ravi Kumar, professor, head of department of chest medicine. I invite Dr. Amar, who is our chief neurologist. I invite Dr. Naveen, professor, head of department of ENT, and I think Kushal from department of nephrology will join us anytime. Well, I welcome you all. Yeah. Well, there are not many studies done with this OSAs. I just want to quote an Indian study, especially South Indian. Bangalore, I think St. John's and Ramaya were involved in conducting the study. They found that in urban, the incidence of prevalence of OSA was around 4.6, and in the rural population it was around 3.7%, but I feel it is just the tip of the iceberg, right? So many a times, first we don't suspect, and second we don't have the patients to come and get the investigations done. So we are proud of our hospital and medical college presenting to you all this advanced sleep study lab, which will definitely be helpful for the population of Tumkur, and maybe we could make a diagnosis and then help them. Their better quality of life, cognitive. We have the psychiatrist here, and who would be telling us, you know, they do go to them with depression. So that is when probably you need to think whether there's some sleep disorder. Well, without much wasting of time, let's deep down into the subject. Ravi, can we start? Please tell us what is obstructive sleep apnea. How do we define it? What is it?
Thank you, madam. That was a nice introduction about OSA. OSA is one of the neglected diseases, as always I tell. Like 80 to 90% of the cases will be missed. As madam told, the incidence of OSA in India, especially in South Indian population, is 3 to 4% in male and 6 to 8% in female population. But as we all know that many of these cases are only tip of the iceberg. So we are missing many patients in our routine practice. So that is about incidence. So why the prevalence is increasing? Nowadays it is increasing because of the lifestyle changes, lifestyle activities and other things. Because sedentary lifestyle, obesity, food habits are changing. So because of various factors, the prevalence of OSA is increasing. Especially many times we tell like OSA patients are obese and they are overweight. That is not the only state. Like in South Asian population, the observation is even it is more common in even thin individuals. It is because of skeletal makeup. Because our South Asian populations, they have the typical skull shape of dolichocephaly, where they will be having anatomical limitations of airway opening and the closure. So in South Asian population, even the thin individuals can come with OSA. So always don't think that only obstructive patients or obese patients will have OSA. Even thin individuals with typical symptoms may have OSA. So obstructive sleep apnea, as we all know that it is the airway disorder, where there will be, especially during sleep, there will be opening, there will be closure of the upper airway, which causes limitation of airflow into the lungs and causing hypoxia, hypercapnia. Over time, it affects the individual in their socio-cognitive way and even related to their diseases. So these patients will have more hypertension, resistant hypertension. Banu might be speaking about that. So CVA and stroke, especially stroke and cardiac heart attacks are about 2 to 3 times more than common population. And they have almost the social issues. If you come to social issues, they might have slept a long time back. Like many times they will be having lack of sleep. They will be irritable. You can just see the patient and and diagnose the patient, because we commonly see OSA patients in our routine practice. By seeing their face, you can able to diagnose them. They will be lethargic. They will be not active, not proactive. Whatever you are speaking, they will be not interested to listen. So by just vision, by just observation, you can diagnose these patients. They have so much socio-cognitive issues. So other than that, we will be discussing about the sleep, how we diagnose in the later part. That's about...
no, I just want to ask you, Ravi, how do we make a diagnosis? When do we suspect, and what complaints do they come to us with?
Yeah. So many times OSA patients are typically obese, not necessarily. And these patients will have, many times they go to ENT people with snoring, or they visit general physicians for various other health issues in terms of diabetes, hypertension, resistant hypertension. So many times it is indirectly we are diagnosing these patients. They will not come to us that I have excessive snoring, I have excessive daytime sleepiness. Many times when we ask them, recurrently, then they will tell that I have these symptoms. They feel that it is their integral part, and it is common, it is normal. Snoring, they will not accept snoring as a symptom, or with snoring they will come to the hospital. Many times indirectly we are diagnosing these patients. These patients visit either me or Madam or Banu in various indirect symptoms, indirect ways. So many times we diagnose OSA patients after a stroke, after a cardiac arrest, after admission for something else, type 2 respiratory failure in the hospital. So these are the various scenarios where we are diagnosing the OSA after the effect, post complications we are diagnosing the patient. Diagnosing the patient initially is a task, is a difficult task, and we have to have high index of suspicion. For that we should have what are the symptoms of OSA and how they present. So typically OSA patients will have obese patients, they have excessive daytime sleepiness, and they have lack of concentration, decreased in their quality of life, and even the work efficiency is decreased. Many times road traffic accidents are common. We ask them any history of near miss. Near miss means survived after a near miss, almost about to get into accident. So near miss. So these are the histories which tell us that they have OSA. We usually grade their daytime sleepiness using a Epworth sleepiness score, which is a score, it's a questionnaire based score where we ask a few questions, and whether the chances of sleepiness during those incidents, based on that we calculate. If any Epworth sleepiness score is more than 10, so it is a type of, it's a common symptom of OSA.
Yeah, I have another scoring system. It is called a stop bang scoring. So stop bang scoring, it is again a questionnaire where patient will give you the history of snoring, getting tired, and being observed that he has snoring, and if at all his BP is high, BMI is high, more than 35, age of more than 60, neck circumference of more than 40 centimeters, and male. So this is called as stop bang questionnaire, where you suspect. See, otherwise most of the times with lack of concentration, loss of interest in others, they might land up in psychiatry and otherwise also. So it's very important, a high index of suspicion is important, that we pick it up earlier so that the complications can be prevented, right? Yes.
Even the history of the partner is very important.
Yes.
Especially night awakenings or witnessed apneas, they are very important. Many times patient may not able to reproduce, but their partners will tell us excessive snoring and witnessed apneas at night.
Yeah, Ravi, you were talking about South Asian people are more prone for it, even though they are thin, that they might have OSAs. And this is because of the anatomical, makeup that they have. So, Dr. Naveen, can you please tell us what are the anatomical risk factors for developing OSA?
Most commonly, what we see here in South Asian population is deviated nasal septum, especially in the nose, and turbinate hypertrophy. And of course, the cause may be allergy for turbinate hypertrophy. And many of the, especially the thin individuals which they come with snoring and sleep apnea, they have some kind of mandibular and maxillary hypoplasia or retrognathia. That's the common thing what we see. Obese individuals, it is easy to diagnose, and there is a way to treat them, weight loss or anything else. But the thin individuals who are difficult to treat, they usually have some or the other type of anatomical abnormalities. Mainly what we see is the deviated nasal septums, sometimes diseases like nasal polyps and other things. And of course we should always look for craniofacial abnormalities like retrognathia and maxillary hypoplasias.
Yes. So more common in children would be adenoid
children, it
and
is almost
tonsillar.
always adenotonsillar hypertrophy. It's almost always the case. Very rarely we see antrocoinal polyps causing obstruction at the nasopharynx and secondarily developing obstructive sleep apnea. But most often it is adenoid hypertrophy and tonsillar hypertrophy.
Yeah, and it's very important to find it out in the school-going age, because their performance would have come down.
Yeah, definitely. They will have some kind of memory loss, lack of interest. They usually avoid playing. They are usually, they want to sit alone, and lot of problems. It is almost, the parents come with very typical symptoms. And we very often we see these children with obstructive sleep apneas. In fact, today itself we have operated on a adenotonsillar hypertrophy patient with very severe, it looked like very severe obstructive sleep apnea. So they do very well after surgery. They are the group of patients where surgery gives very good results. Now, unlike in adults where surgery still has got little limitations, but in children they do very well.
Yeah, because we know the cause.
Yes.
Okay. Ravi, talking about these anatomical malformation or whatever you call, is genetic thing implicated in OSA?
Yes, ma'am, definitely. Genetics play a role in almost all the diseases. Even OSA, with a family history of OSA, the chances of the kids or next generation getting OSA is very common, because family history is very important in OSA. Usually they will be obese, their lifestyle will be almost similar, and even the skeletal makeup, the structure, everything will correlate to their parents. So definitely genetics play a very much role in OSA.
Dr. Banu? Well, OSA with cardiovascular disease. See, OSA in patients who are known to have cardiovascular diseases or cardiovascular diseases like congestive cardiac failure presenting with OSA. I want you to throw light on this, both of them.
So to start with, I think obstructive sleep apnea is not just obstructive sleep and apnea. It's more of a systemic disease rather than a localized disease, because there will be episodes of deoxygenation and reoxygenation that happens in the body, which will lead to hypoxia, hypercapnia, and sympathetic overactivity. So whenever there is sympathetic overactivity, we all know that there will be vasoconstriction, both systemic and pulmonary. So all these things will lead to increased pro-inflammatory cytokines and pro-thrombotic mediators and platelet adhesion molecules. So all these will lead to a systemic inflammatory process rather than any localized process. So this will lead to all related systemic illnesses, which could be cardiovascular or neuro or other skeletal-muscular and neuropsychiatric illnesses. So cardiovascular, whenever there is sympathetic overactivity, release of all these things, all these mediators, so there is definitely increase in, as I told, systemic diseases, especially related to vascular. So to start with, hypertension. So we all know that hypertension is a vascular disease, systemic vascular disease. So OSA increases the risk of hypertension. So it is found that the prevalence of hypertension in OSA patients is more than 60%. And it's not just the association, hypertension, OSA itself is one of the independent risk factors for hypertension. So when we treat OSA in hypertensive patients, the chances of controlling the blood pressure and reversing the hypertension is higher. So we should suspect OSA in few patients, especially in resistant hypertension patients or non-dippers. We call dippers and non-dippers. Those who are non-dippers also, we need to suspect hypertension. So we are giving multiple drugs, the BP is not getting controlled, and we need to evaluate for the obstructive sleep apnea. The scoring system, what sir has told, madam has told, we should use it, and we should suspect OSA and get the patient evaluated. Next, diabetes. So as I already told, it's a systemic disease. There will be pro-inflammatory mediator. So all these mediators will increase the chances of metabolic syndrome, insulin resistance, so which eventually lead to insulin resistance, lead to impaired glucose tolerance, diabetes, uncontrolled diabetes, and complications of diabetes. So this is one more disease that is associated with OSA. Again, it's an independent risk factor for diabetes and hypertension. Coming to cardiovascular disease, so all these pro-inflammatory mediators will lead to endothelial dysfunction. So endothelial dysfunction is one of the major pathogenetic mechanism behind atherosclerosis. So there will be accelerated atherosclerosis. So nearly about 2.6 times increase in coronary artery disease in OSA patients. And it is found that OSA itself is an independent risk factor for coronary artery disease, both stable and unstable. So there is increased chances of acute coronary syndrome by about 4 to 5%, especially during the early morning hours, 12 a.m. to 6 a.m., whatever that period is there. In that bracket, the risk of ACS is very high. So the pro-inflammatory markers will all lead to increased atherogenetic mechanism. And the next thing is sudden cardiac death. So sudden cardiac death is also increased by obstructive sleep apnea as an independent risk factor. So those who have obstructive sleep apnea, they have higher chances of sudden cardiac death because of various reasons, commonly arrhythmias. So arrhythmias are also higher in cases of obstructive sleep apnea, both brady and tachyarrhythmias. So there can be sinus bradycardia, which commonly happens with even mild OSA. So AHI of 5 to 10 also, they can have sinus bradycardia. So with the severity of OSA, if it is increases, it can lead to sinus pauses, second degree AV blocks, atrial fibrillation, atrial ectopics, atrial arrhythmias, ventricular tachycardia. All these arrhythmias can happen with obstructive sleep apnea, independent to any other risk factor. Even if they don't have any conduction system abnormality, they can have arrhythmic disturbances.
Yeah, of the arrhythmias, more common is atrial fibrillation.
Yes. So OSA could be one of the causes for lone AF.
Lone atrial fibrillation.
Yes, ma'am.
Added to that, Banu, like recently I got a patient, he's a young male, around 35 years. So he presented with AF. to one of the hospital, and he was evaluated and referred to Jaydeva, where he was evaluated, no nil cardiac, nothing. So he had OSA component, referred back. We did the sleep study. AHI was around 45. So started treatment, he's doing fine. So the presentation was AF.
Did it revert back?
Yeah, he's fine now. It is reversed with treatment, but the cause for AF is
We
OSA.
found what the cause is. So it's either way. OSA as a risk factor for hypertension, coronary artery disease, arrhythmias, diabetes, coronary artery disease, they are all predisposed to OSA.
So it's a vicious cycle. So it's a vicious cycle, especially in heart failure, OSA patients. So OSA will lead to heart failure, and heart failure will worsen again obstructive sleep apnea because of the congestion. So they'll have fluid overload. So they'll have pharyngeal congestion, obstruction. So nasopharyngeal obstruction is also quite common. So all these things will lead to CCF, worsening of the CCF.
The same thing may be the same mechanism in CKD. So patients with CKD are more prone to, around 60 to 70% of them will have OSA. And treatment of CKD, maybe an intensive dialysis or so, will help them for them to come down with OSA. Ravi, please comment on that.
Especially in renal practice, the prevalence of OSA is very high. As literature says, 60 to 70%. I was speaking with one of my friend who is a nephrologist. So our thesis topic was OSA and CKD. So she found that more than 90% of CKD patient had a component of OSA.
Yeah,
it was proved
around few of the studies say around 60 to 80% of them.
Literature says that, but according to our study, it was more than 90%. That's what they told. So the prevalence is very high, especially in CKD, probably because of all the metabolic involvement, pro-mediators and cytokines mediated renal injury. Could be the cause, and even these patients will have edema, which causes the edema of the especially upper airway, which is one of the cause for OSA in CKD patients.
Again, it's either dialysis or transplantation, or any of them might definitely help these patients with OSA.
Many times when these comorbidities are there, either treating OSA or treating the other condition might help each other. Like it's a vice versa.
Okay.
Even treating OSA might help CKD per se as such.
Okay. Dr. Amar, please talk about the common neurological events which occur with OSA.
Actually, OSA has been, as I was telling, is an independent risk factor also for stroke. Apart from other risk factors of hypertension, diabetes, and obesity and sedentary lifestyle, OSA itself is a risk factor for stroke, as also has been found out that there's a strong association of OSA with neurodegenerative disorders like Parkinson's disease.
Yes.
Parkinson's disease and Alzheimer's disease and other neurodegenerative disorders. And as sir was telling, patient will not present with OSA. Patient will present with other non-specific symptoms where you have to suspect OSA. For example, patient can present to neurology with different symptoms, like patient can have recurrent morning headaches, which is not getting treated because he's having recurrent sleep disruptions. So he gets up early in the morning with headache. That headache will not go with whatever you treat, the headache will not subside. Those patients can have, you have to suspect OSA. Patients can have difficulty in concentrating. The concentration is not able to focus properly. In the daytime somnolence may be there. They may present with memory disturbance also. Patients, it has been seen that patients with mild cognitive impairment, if you screen them for OSA, we may slow down the progression of these patients progressing into dementia later on. So that we'll have to keep in mind. And also patients may present with insomnia or excessive daytime hypersomnia in the daytime.
Especially in elderly, this is so very common.
Yeah,
Sleep disorders are so common.
Actually, even I have not been actively asking questions about OSA.
Yeah, that's what I confessed. From now onward,
We have to actually look for
promise.
the incidence of OSA, because the studies have shown the prevalence of OSA in stroke has been varying between 50 to 70%. Of all strokes may have preceding OSA. So it has been recommended now. The recommendation is we have to screen all patients with TIA as well as stroke for OSA. TIA because we can prevent stroke in OSA in those patients, and stroke because we have to prevent recurrent stroke. So that recommendation is you have to screen all patients of TIA as well as stroke for OSA.
Okay.
That is the recommendation, but I don't know how much feasible it is in our setup. But
maybe we can take it up as a project.
We can take it up.
Yeah, take it up as a project
We
and
can
look for.
We can do a study and.
Yeah, people with OSA are at high risk of developing stroke.
Yeah.
My question again is, a person has already developed stroke and he's prone to develop OSA. Is that true?
Is prone to develop OSA?
Yeah, he has a stroke. He has stroke and he develops OSA.
Probably some posterior circulation strokes like brainstem strokes, which may affect the sleep
Lower
centers.
cranial
Sleep centers. That will cause sleep apnea as such, but not obstructive sleep apnea, but central sleep apnea. It can cause.
But again, we need to evaluate.
Yeah.
So that we need to subject him for polysomnography so that we make a diagnosis whether it is central or whether it is obstructive or whether it is a complex. So it's better
Whether
to
it's
do
mixed
both
component,
of them.
mixed
Yes.
component
Yeah.
is there, or separate OSA is there.
Okay, thanks Amar. Ravi, well, we have suspected. Now we know what all problems they can come to us with. We know the complications also. How do we make a diagnosis? So definitely I need to say that this patient has OSA. How do we go about it?
When patient, many times these patients will be either referred from one of the specialists because they have visited them for some other complaints, or one event has already happened. So they will be coming to us, and many times we take proper history, whether it is exactly OSA or something else. After taking thorough history, we examine them. Usually they will be having, as anesthetist people are there, they will be checking the upper airway for intubation. So usually their Malapati score will be more than 3. So you cannot able to see the posterior pharyngeal wall on examination. We do neck circumference, waist circumference, and body mass index. Usually these patients will be overweight or obese. So not necessarily, as I told, that is one marker. Usually waist size is very important than neck circumference. That's what the recent studies say. Waist circumference is very important to assess the severity of the disease or to diagnose the OSA.
Otherwise, neck circumference more than 40 centimeters?
More 17 inches.
Around
16
40
inches, yeah, 16 inches for male and 17 inches for female.
40 centimeters.
45 centimeters. These are the markers with which we suspect OSA, and typically these patients will have excessive snoring, excessive daytime sleepiness, witnessed apneas, nocturia. They will get up for urine every night. They will get up with morning headache, and daytime concentration will be altered. They will be having neurocognitive issues. They will be having near misses. They will be having comorbidities like hypertension and resistant hypertension. Many times they will be taking 2-3 tablets for hypertension, obese. So these are the things when we suspect OSA. So once we suspect OSA, we ask them to undergo sleep study. Sleep study, overnight what we call it as overnight polysomnography, where patients will be sleeping in the sleep lab, where we will be monitoring the EEG to stage the sleep. We will be monitoring the snoring, we will be monitoring the flow and the chest and abdominal movements to differentiate whether it is central apnea or obstructive apnea or mixed apnea. And we will be even monitoring the periodic leg movement. This is what we call it as, there is a entity called periodic leg movement syndrome, PLS syndrome. And also we will be monitoring the position of the patient associated with sleep and apneas. Even positional apneas are common, which can be treatable or correctable. Along with that, these patients will have other sleep disorders, especially like sleep talking, paroxysm and all, which can be diagnosed with the level 1 study. And there is an entity called narcolepsy. These patients, not only sleep study is done at night, even sleep study can be done at daytime. So it is called multiple sleep latency test. So we are subjecting the patient for sleep, like we are inducing or we are providing such a facilities to go for sleep. So if they go for sleep within a before the prescribed time, like normally we take about 20 minutes to go for sleep. So if they are falling asleep very early, that is called increased sleep latency. And along with that, we will be monitoring what stage of sleep. So if they are entering directly REM stage, that is called narcolepsy. So they are sleeping and entering directly to the REM stage, and they lose their position and they will fall off. So this is to check narcolepsy. We do during daytime multiple sleep latency test and to check the suddenly entering to REM stage. So we do sleep study. After sleep study, we have the process called scoring. We score the sleep, like a sleep stage should be scored accordingly, then only we can get the apneas or hypopnea score. Without scoring the sleep, it's very difficult to get the reports, because if it shows vague stage, then the reports will not be valid.
Correct.
So patient has to sleep. During the sleep only, these apneas and hypopneas are recognized. So after scoring, we give a consolidated report. What is the apnea hypopnea index? Apnea hypopnea index means number of apneas or number of hypopneas per hour. So how many times there is a airway compromise or choking happening in 1 hour. So if it is more than 5, we diagnose them as OSA and grade according to the severity, like 5 to 15 mild, 15 to 25 moderate, more than 25 severe. Based on that, we start treatment, ma'am.
So less than 5.
Less than 5 is normal. Anything
normal.
more than 5?
No, I do have a very practical question. The patient comes to you. The day one, it's a different place where he is not used to sleep, you know. And what if he doesn't sleep well on that day?
We have some, we have given some instruction to the patient. So they're not supposed to sleep on the previous day, or they have supposed to get the clothings according to their comfort. And even sometimes we ask them to get the pillow of their comfort. Or some patients who are alcoholics, who never sleep without alcohol, or sedatives, we advise them to get alcohol or even their tablets, regular sleeping tablets.
No, but they are all the responses. Patient develops OSA.
No, we are
Dr. Ravi, you are on record. Remember that.
No, the patient will not sleep otherwise. We are diagnosing the patient in their routine state, not in the altered state. If they are not sleeping, it's difficult to diagnose them.
Yeah, maybe you call them the next day, they get used to, and then...
Yeah, many times for such patients, if the study fails, we can arrange the study at home, their home, and what we call it as home study, which is a limited study, where we cannot do level 1 study. We can go for level 3 study just to check OSA, chest movements and flow. By checking that, we diagnose OSA.
Okay. Now that we have made a diagnosis of OSA, either mild, moderate or severe, how do we go ahead? How do we treat? Important is lifestyle modification. Well?
Yes. Like many times, lifestyle modification is the treatment of choice, but it is difficult. Like for anybody, if you say like you lose 15 kg weight, then it's a practical issue, it's not possible. Or change entire food habits, it's not practically possible. So many times, many things looks wise, but practically not possible to do. So such patients, we have to go for either medical or surgical interventions. So many times, once we diagnose OSA, we also take ENT opinion to rule out any treatable causes like adenoids or tonsils, especially in children. It's many times surgically we can treat them. For adults, it's after ruling out ENT causes, we can go for medical management. Medical management, many times it's very difficult to counsel them and to buy the machine. So we use CPAP as a treatment of choice for obstructive sleep apnea after ruling out surgical interventions. So sleep apnea is comfortably treated by CPAP. So which is one of the treatment which we are very much satisfied, even patient is very much satisfied. So many times we hope for the patient to come for follow-up. This patient will never come for follow-up because they will be so comfortable and they will get rid of their problem and they will be happy. So many times they will come back with either mask leakage or some other issues with a machine, but not with the health issues. So the treatment is so comfortable and patient is so comfortable with the CPAP. After 1 week, you can just see the changes in their neurocognitive issues, and even over time, even other comorbidities are improved a lot.
Okay. There are drugs that improve OSA, like say anti-inflammatory drugs, and then bronchodilators, diuretics. Probably we were talking about congestion and these things. Do you use any of these drugs? Like say anti-Parkinsonian drugs also might help in OSAs. Have they tried any of these drugs?
Many drugs they have tried. Even they have tried stimulating the hypoglossal nerve. So there are many studies, but we are not getting such a good result or such a good outcome with all these drugs. They are not of
So
much
one
use.
is lifestyle modification, second is CPAP. Dr. Naveen, can we talk about the surgical management?
Before going to surgery, we should understand how we evaluate the patient once the polysomnography is done. Because not all the patients are surgical candidates.
Yes.
And the gold standard for the treatment of OSA is always CPAP. But there are certain group of patients, especially the young individuals, where the compliance is the issue because they don't want to sleep with the machine on. So where the surgery is indicated or patient wants us to evaluate for surgery, the next step is to understand where exactly the obstruction is happening. There are 3 areas where the obstruction can occur in OSA. One is retropalatal area behind the palate, in between the palate and the posterior pharyngeal wall. Next is retroglossal area behind the base of the tongue. Next is hypopharyngeal area, mainly the epiglottis. So to identify where exactly the obstruction is happening, we do something known as DISE, drug-induced sleep endoscopy. It's the regular flexible nasopharyngoscope is used. Obviously it is done in operating room setup. Patient is sedated under BIS monitoring, and normal sleep is simulated. So otherwise, if he goes very deep into anesthesia, the results are not valid. So under BIS monitoring, normal sleep is simulated, sedation is given, and during that, under flexible nasopharyngoscope, the airway is evaluated. So we identify the area of obstruction. If it is retropalatal, we need to also identify what type of obstruction he is having. It may be anteroposterior compression, it may be lateral compression, it may be circumferential compression. Sometimes the obstruction is at the level of base of the tongue. Palate is absolutely normal. So we need to identify how bad is the obstruction at the base of the tongue. So depending on the DISE results, surgery is planned. Most of these patients will require multi-level surgeries because the results of single-level surgeries like uvulopeltopharyngoplasty and those things which were done earlier are not really great. And most of these patients will require some kind of surgery in the nose. That is part of the OSA surgery. Most of these will undergo either septoplasty or turbinoplasty or something, which is part of the multi-level surgery. But next, coming to what surgery they need, apart from the nose, then the DISE results are extremely important. The retropalatal area, if there is obstruction, the good old surgeries like uvulopeltopharyngoplasty, lateral pharyngoplasty, and there are certain palatal strengthening procedures, palatal implants. So these are the surgeries which are very helpful. If at all the obstruction is at the base of the tongue level, which is around less than 20% of the patients with OSA will have obstruction at the level of base of the tongue. They require procedures to reduce the size of the base of the tongue. It may be tongue base reduction, midline glossectomy, or there are surgical procedures where used to pull the base of the tongue anteriorly so as to create some space in the retroglossal area. So like hyoid suspension, maxillomandibular advancements. So, and as sir was telling, the glossopharyngeal nerve stimulation, there are implants.
Talking about the implants, right now there are AI assisted implants where the implant is here in the subcutaneous this thing, and you have a mobile like thing which has an app, and you have.
The basic idea here is to create more space behind the tongue, if at all the obstruction is at the level of base of the tongue, because as the nerve is stimulated, it pulls the genioglossus anteriorly, and there is the space which is created. So of course AI helps in identifying the the apnea event. So whenever there is an apnea event, the implant stimulates the glossopharyngeal nerve and it pulls the hypoglossal nerve.
Will
and
get
pulls,
up then.
it just pulls the muscle and creates the space.
Yeah, by in EEG can sense it.
Yeah, so the AI is used in that sense, but still the implant has to be placed to the nerve. But again, most of the surgeries are mainly supportive.
Yeah.
Many of these patients eventually may require CPAP because still the OSA surgeries are in very nascent stages. They are not really well developed. Many patients, they give good results initially, but after 6 months, 8 months, again, they start developing OSA symptoms. So patients who are not really compliant to the CPAP, and patients who require higher support, higher pressure support in the CPAP, where it becomes very uncomfortable for them to sleep, those are the patients who will require surgery. And of course, the patients with craniofacial anomalies like mandibular, maxillary anomalies, the treatment is some kind of orthognathic surgery like maxillomandibular advancements. So that helps those patients. So surgeries for sleep apnea are not really single surgeries. Most of these patients will require multi-level surgeries at the same stage.
Yeah, so ultimately it's the lifestyle and also the CPAP more than the surgeries.
Yeah,
maybe advancement
one
is
second.
required.
I'll just remember one incident regarding this. One of my friends in Ballari, her mother is a gynecologist who practices in Ballari. So she, for the couple of years, she had this fatigability. Even with 1 or 2 surgeries, she used to feel severely fatigued. So all other systemic evaluation was normal. She was not that obese also. BMI is near normal. So, I mean, nothing was found. So she was been suffering, and then somehow somebody suggested him regarding the sleep study. So she underwent sleep study with a AHI of nearly 50.
Severe.
Very severe sleep apnea, and then she underwent surgery. So she underwent surgery, and now she is doing well without any CPAP, and she is practicing very well.
Lucky for her.
So I think though it is in nascent stage, for individual cases maybe after detailed evaluation, so I think it may help for a few people. I think we should still consider.
Most of the studies have shown that after sleep surgery, patients as a symptom, they do really well. Their upper sleepiness scale improves, everything improves. But as far as the AHI is concerned, they may not do really well. The AHI score still will be on the little higher side, not really normal. But as far as symptoms are concerned, they do well. So that's what is found. The correlation between this AHI and the symptoms are still controversial. That's the problem. All these surgeries, they do very well symptomatically, but when the sleep study is repeated, ultimately, the AHI scores are not really.
So the only abnormality in her was raised CRP. So HSCRP was, very high. So then they started evaluating and then found to have, because it's a systemic disease. So any diagnosed case of OSA, I think evaluation, a systemic evaluation is very important. A general evaluation in the form of blood sugars, blood pressure, body weight, BMI, thyroid profile, cardiac evaluation in the form of ECG, echo, maybe a stress test also. So systemic evaluation is also very, very important before we jump into, because many people have heart failure with normal ejection fraction. NEF is quite common in OSA patients. Isolated pulmonary artery hypertension, very common. So they may have associated COPD, but even in the absence of any primarily lung pathology, they can have isolated pulmonary hypertension. So in such patients, if there is no evidence of pulmonary thromboembolism, I think the next thing we need to consider is a sleep apnea. And also along with this, there can be other things that can be restless leg syndrome. Few people will have continuous restless leg syndrome.
And one more thing which we didn't discuss was stress. Stress induces OSA.
Stress and lifestyles, like as Madam told, stress is one of the risk factor for OSA. And even alcohol and smokers.
Yeah, smoking and alcohol.
They aggravate OSA. So stress, OSA, these are all, it's a lifestyle related problem. Definitely stress, obesity, behavioral problems like health, diet, everything matters in OSA.
Yeah.
Though echo is normal, I think clinically those who have features of heart failure with normal ejection fraction. So I think clinically if they have cardiac failure, once the heart failure stabilizes, I think we need to suspect obstructive sleep apnea in those patients.
Again,
and
that
get it
also
evaluated.
can be taken up as a project, Banu.
Very true, madam.
Nilesh,
We have lot of such patients.
We
actually.
remember one patient, like she was one of our friends' sister. She was admitted in THS, pulmonary hypertension. So she, as you told, like tiredness, dyspnea, minimal exertion, and weakness. So she was admitted, hospitalized. We evaluated for pulmonary embolism, pulmonary hypertension, isolated pulmonary hypertension, CT pulmonary angionormal, everything was fine. She had a minimal sleep disturbance, not typical case of OSA, but we did sleep study with HI of 50-55 and she is doing fine.
Was she obese?
No, not obese, around 25-26 BHA, PMI.
Banu, now that we have this advanced sleep lab in our hospital, what is the protocol? How do we refer the patients and how does it go up?
So, clinically, if we suspect obstructive sleep apnea with whatever the symptoms we have, like, of course, snoring itself is not sleep apnea. Excessive snoring, which is beyond the expected levels, which is disturbing other people in house, and then there can be witnessed apneas, hypopneas, so insomnia and lack of attention and tiredness, early morning headaches. So these are all few subjective symptoms. And night times, if the patient is having restless leg syndrome, that is even during night times the person is banging his legs or moving his legs. So all these things could be subtle features of obstructive sleep apnea. So if we suspect, then we need to send the patient for sleep study. And the sleep lab and sleep study, everything is under the Department of Pulmonology headed by Dr. Ravi Kumar. So we have actually discussed and come to a protocol how to get it done. So we evaluate clinically and then refer the patient for sleep study. I think Dr. Ravi should be a better person to discuss.
So once patient is referred to our department, we evaluate the patient with clinical examination and with the proper history. We advise them for sleep study. We give the date and time for the sleep study. We will maintain all the records of these patients, and this patient will be instructed how to come to the sleep study on that particular day. Usually the sleep study starts at 9:30, 10 o'clock. Our patients' routine time, like they have to come half an hour to 1 hour before their routine sleep time. And with the instructions not to take nap during daytime, and they have to shave their chin, their beard properly without oil, and various other instructions will be given to the patients. So patients will be they will come to the hospital. They go to ER initially. So in the ER, all vitals parameters will be checked before sending the patient to sleep lab. So after checking the vitals, patient will arrive into the sleep lab. Technician will be there. Technician will assist the patient to connect all the parameters, and he monitors the sleep. Once sleep study is done, next day morning, patient will be sent home in the morning, and will take at least 1 day for scoring the report, and the next day report will be ready by evening. So we call the patient back. So once OSA is confirmed, we will take ENT opinion regarding any surgical interventions can be done or anything which is treatable. So once it is, after discussing with ENT people, so we will proceed for, if it is a medical management, we will proceed for prescribing CPAP. And once we prescribe CPAP, like we have to ask the patient to come for follow-up after 2 weeks. So there will be a decoder in the in the CPAP machine. We will reanalyze the AHI, what was there in the study, and after using for 15 days. So we can analyze AHI using that machines. So after 3 months, we are calling them for once again for second follow-up to check for AHI and patient's comfort. So this is the protocol what we are following. Once it is diagnosed, once we prescribe the medications or CPAP, we refer the patient back to the respective consultants for further management and evaluation needful.
Okay, then before we end the discussion, the hall is open for discussion. Any queries, anything else to add to us, to our discussion, you are welcome.
So
Your experiences
we
with
can involve
the
psychiatry, Dr. Kirti, for
yeah, the
psychiatry.
physicians are all here. And one more important thing, OBG, patients' pregnancy with OSA, there will be fetal growth retardation, and they develop pulmonary hypertension. Growth retardation is always there. So it's very important that you pick it up early in the pregnancy so that she can be helped. It has been shown that there will be fetal growth retardation. Would somebody want to add anything?
No. Snoring is a common symptom. Like it's 50 to 60% of the people snore in one or the other way. It is a symptom. But all OSA patients will have snoring. Almost 90% of the OSA patient will have snoring. So as sir told, like snoring in different ways. Like they will be having severe snoring, disturbing the family, disturbing social issues will be there. Witnessed apnea is very important. Patients, usually their pet partners, they will tell us, like they will stop snoring for a while, and we will be like worried what happened to the patient. He is not breathing for a while. So that is the important history what we consider. Along with that, excessive daytime sleepiness. So if they have any other comorbidities like resistant hypertension or obese, so excessive daytime sleepiness, many times it's there in 60 to 70% of the patient. Another 30% of the patients it may not be there. So high index of suspicion should be there with other angles.
Ravi, what you have left out is GIT. Is there any communication? Gut-brain axis? Vinod? Gut-brain axis.
Actually, for that,
OSA.
Vinod is there. Vinod, I have a question. Like one of my patient, madam, severe OSA, underwent bariatric surgery, and she is doing fine.
Yeah.
So even you.
Yeah, that is also one of the method of treating OSA is get a bariatric surgery done.
Obesity is nearly about 60 to 70% of the people.
Definitely.
I think, yeah.
OSA. So
The first surgery that is suggested is bariatric surgery. Rather.
we usually advise weight loss. Once they doesn't respond to means exercise, diet, all those things, then only last option is weight loss. Means surgery, bariatric surgery when they have OSA.
Maybe more than the ENT surgeries, bariatric surgery would be
If they're,
useful. No, I'm not promoting.
if they're very obese and BMI is more than 40, then we advise surgeries. These people usually have NAFLD. NAFLD is more associated with obstructive sleep apnea.
Yes. Anything else?
I think just isolated snoring need not, it doesn't require any evaluation, but if as discussed, excessive snoring is one thing, and associated with other, heart failure, if the patient is having heart failure with snoring, so if the patient is having obesity with snoring, if the patient is having resistant hypertension with snoring, so all these things will have added, so.
Yeah, you have those questionnaires where they can tell you that they are going in for most.
It's coming to us.
They don't, I know.
They are meeting cardiac people means they have one IHT or resistant hypertension.
It's already a systemic disease, so it is not a localized one.
So I think
sometimes we identify OSA in the bystanders, the patient and the bystanders. Those who are coming with the patient, they will be having some subtle symptoms and they will have this. Then we advise them to go for sleep.
they will not come. They will not come. They are bystanders. So if they have some disease, if they are visiting a doctor, if they are suggesting for sleep study or something, they will come. So you cannot go and ask somebody who is smoking on the road to quit smoke. So when they come to you with COPD, you can tell them. Yeah, if positional OSA, positional snoring is there, so we ask them to lie in the left lateral position. Left lateral position is the best position. So in the initial stage, even the positional change is one of the treatment for snoring. So we advise them to keep a tennis ball in the pocket, back pocket, and sleep on the left side. So left lateral is the best position.
What do you suggest about prone position or something like that? Sir, some studies say that 50 to 60% patients get benefited with prone positioning. Is there any data on it, sir?
Again, it cannot be consistently done, right?
Yeah, madam.
Yeah, but
difficult,
I know maybe it is
difficult.
theoretical, putting the patient in the prone position and how long can he sleep like that. There are few studies which say prone positioning is good.
Psychiatric issues.
Yes.
We are like the fourth lion in the Indian emblem. We are not seen, but many of them will come to psychiatry, or most of them will come to psychiatry with depression, anxiety, and other things. So definitely it requires a proper screening whenever we see patients for various psychiatric disorders, because any sleep disturbance is a risk factor for almost all psychiatric disorders, ranging from dementia to childhood disorders. I would say where these sort of level 1 sleep studies will come for our rescue is differentiating between REM and NREM sleep disorders, because the treatment is more or less tailored, and we can make it bespoke treatment for patients. So that's where I feel level 1 studies will be very, very helpful for our patients.
And one more important about psychiatry and OSA is certain drugs like benzodiazepines, opioids, muscle relaxants, they have worse effect on OSAs. So we need to ask them about the drug history also. It's very, very important.
And as you mentioned, alcohol and smoking cessation, I think that definitely has its role. And you were saying, as if they are not comfortable on that day, ma'am had a very practical question, what to do if they don't sleep on that day. So we can have Z-drugs which can be used. There is evidence to say that can be used in sleep studies. Because especially to diagnose obstructive sleep apnea, but it may overshadow other sleep disorders. But if it is purely for obstructive, we can certainly use Z-drugs like zolpidem or zopiclone. So that will not relax the muscles so much as benzodiazepine. So that's something that you can certainly make use of it.
Okay. Thank you then. I think we shall conclude.
One
Ravi?
more. How will you deal with the chronic cases of OSA or who has already developed OSA syndrome?
So almost we are seeing the patient with OSA syndrome only. That is the common scenario in our practice. So many times we will be seeing patients in ICU, bedridden or on ventilator. We are diagnosing OSA. So usually such patients, once we stabilize them, so then we subject them for sleep study and then we start treatment. So it depends, like chronic means many times they will have central apneas or end stage OSA. There we prefer BiPAP rather than CPAP in certain conditions, especially obese patients. They have the component of obesity hypoventilation syndrome with OSA. Or central apneas, we prefer BiPAP with ST mode.
That will be the initial management for the stabilization. What will be the definitive management? Will it more surgical or medical only will helpful for the patient?
Right now it's only the long term.
Long term, okay. Like long term surgical, as sir told, surgical interventions are not very well established. So we prefer to give medical management in terms of either CPAP or BiPAP over long time. So they will be doing fine with the CPAP.
But again, long term, the compliance is a problem.
Yeah, compliance is a problem, but definitely once they know the importance of the CPAP and get used to it, this is wonderful. Like nothing like they cannot leave even one day, or they cannot even a day if they go out, they will get the CPAP machine. So that's how they are. Even they can forget their family and wife. They will get CPAP. That's how the dependence on the CPAP.
That's what I'll be telling for my patients. So if they're on CPAP, I'll ask them that will be their second wife, because that's how they have to lead their family with it. So I think that's what it is.
Yeah. Even you can carry CPAP in the flight, so you have to get a prescription from your doctor. Or it's so common that in the airport, if you say it's a sleep machine or a CPAP machine, they will accept. You can carry on. So it's so common. People are moving with CPAP very often.
Many of them are using for many years.
Once they get used to it, the compliance is not an issue, because at the end of the day, sleep is everything, right? So they have to sleep well. So they can do anything for sleep.
Yes.
But at least we can give surgical option for them.
Very true.
Especially the patients who are thin, not obese. Surgery makes a lot of sense for them because they do well. But obese patients doing surgery, usually outcome is not really good. Because for them the obesity itself is the cause. So a lean individual obviously has got something else. There is some anatomical issue with him. They do well with surgery. Probably they will be taken out of CPAP. But obese individuals, it is very difficult to take them out of CPAP even after surgery. Probably their compliance to the CPAP will improve because the pressure requirement will become very less.
I have actually a few patients who were obese, and now after starting CPAP, they have lost some weight and they're clinically doing well.
Indirectly, it affects their quality of life. They'll start moving around, they will be active, they will involve in various activities, and even physical activity will improve.
Obesity, lack of sleep is another reason for them to become obese. So they
lack of sleep is an appetizer. They tend to eat more. Yes. Even that is, some studies says that they start eating more and...
Heart, the progression like inflammatory condition and all, will it reverse? Like patient has developed fatty liver, going for metabolic syndrome, dyslipidemia, everything, borderline hypertension, pre-diabetes. So patient has been started on CPAP. If you follow up that patient for the 3 to 6 months, will it just halt the process or will it reverse?
Almost the studies shows, especially CVA and cardiac events, the chances of getting these events are similar to the normal people. So after CPAP usage, that's what studies say. So almost not reversing, almost it's equivalent to general population.
Few people actually, I think it reverses also. If it is an isolated cause, definitely yes. The requirement of medications comes down significantly, and readmission chances also comes down significantly. So it's almost like near reversing, yes.
Especially hypertension. We have seen many patients who have stopped medications.
Heart failure, hypertension.
Sir, just to answer what Dr. Vivek was asking, what to do in chronic syndromes, as well as, and also it made a sense that, and also resisting conditions where they are not cured by either surgery or that's what you meant, isn't it? So if they are not cured or fully symptom free either by surgery or by CPAP machines, I think then we have to think about multidisciplinary approach where everyone comes into picture, rationalizing their medications, looking if there is anything is causing, and involving dietitian to reduce their weight. So it should be a holistic approach. So
I think even from the initial stage, it is the multidisciplinary approach.
We advise them for lifestyle modification. That is important. That should be continued. That should be there along with the treatment. So definitely dietitians, we refer them for dietitians for good diet control and weight reduction. That is one additional things we do for all the patients.
And one of the theories, what they say is people who are struggling with depression or anxiety, they have problems with their muscle tone itself. So some sort of cognitive behavioral therapy or relaxation
Even
techniques,
antidepressants also might help in
they help,
many
they
cases.
help. So those things will certainly help in chronic and resistive conditions.
Thank you. Then I think
Psychological
we can
disorders are very
conclude.
common.
Yeah. If there are no more questions, I think, yeah, Osar has a question. Yeah.
Even in our field, they say in obstructive sleep apnea cases, especially where the mandible is deficient or short, they say with the patient who are non-compliant with the CPAP, we give mandibular advancement splint or mandibular advanced devices, which the study shows like it increases the compliance in those patients. And especially in tongue-based collapses, it's not as Sir told, in circumferential or concentric collapse, it will not help, or in lateral collapse also it will not help, only in tongue-based collapses. In those cases, if you give mandibular advancement splint or the devices, it's going to help. And in young individuals, where the nasal airway is narrow, we can advise for rapid maxillary expansion to increase the nasal airway. And these are the things which in our field also we contribute for the OSA.
As you said, sir, orthognathic surgery has immense value in certain patients with obstructive sleep apnea, especially in craniofacial anomalies.
So, orthognathic surgery will be basically it will done in non-growing individuals.
Yes.
But in young individuals, we have myofunctional appliances. We can induce the length of the mandible.
Oh.
So we can advance the mandible and we can induce the length of the mandible. In those cases, we can avoid orthognathic surgeries.
Oh. I think I thank all the panelists for taking your time here, and I think it was a really good discussion, and I thank all of you